everybody else see the slides well? I'm seeing kind of a tiny.
I can see them well.
I think they're
Okay.
coming through fine.
Okay. So do I have remote control access now?
Yes, you can just hit the next button with your mouse or on the keyboard, and it should work that way.
Okay. There it goes. It's a little delayed on my end. So I am going to just talk about the progressive nature of type 2 in a different way than I usually talk about it, but in a way that I think is helpful. So the first slide here, the role of blood sugar, the simple explanation, we've probably all seen in some form or another. And I've used it with patients. I've used some form of it with just about everybody. So it's all still true that we need to talk to people about how they eat and what happens when they eat and how it turns into their blood sugar. So there's a on, and they need to be able to do that, to understand that. And then when it gets into the bloodstream as blood sugar, that's a good thing. Sorry, I'm just looking at the chat box to see if anybody was trying to tell me they couldn't hear. And then we usually explain to people that the insulin gets into the bloodstream as with the blood sugar and opens the door to all the cells of the body, and that's what's supposed to happen. So I am advancing the slide by one, but it's taking a second. And if Mitra, you can advance it, because it's not moving for me.
Okay, I can try to advance the slides for you. Is that good?
Yep, there. It just delayed, and we'll only be on this one a second. So this is just, if there's no insulin, either because they have type 1 diabetes, or there's insulin, but the cells don't allow your insulin to work, which is called insulin resistance, then obviously the nourishment is not going to get into the cells, at least not all of it. So next slide. Okay, now this slide, I am not going to spend much time on it at all, but it is a more advanced way of looking at type 2 diabetes. So the interesting part about this slide is that there's at least 8 things going on that's not working right with type 2 diabetes. And there's other slides that would show you which drugs on which of these defects. So we've got that's good. You moved the slide, and that's great. So I wanted to look up to make sure nothing had changed in diabetes care for this year, and nothing has changed. So defining pre-diabetes is still the same, an A1C in that range that you can see. A fasting blood sugar is still the same, 1 to 125, and then you can do an oral glucose tolerance test. And then next slide. And this is still the ways we diagnose diabetes today. And I put these slides in here mainly to say a lot of patients don't know this. And so over the years, somebody with diabetes, full-blown diabetes, will tell me their blood sugar is 175 and they don't have diabetes. So it's always good to make sure the patient understands what the definition of diabetes is, at least by the numbers. Next slide, please. So, and you can go past the thinking cap guy. I just want to present another way of looking at this because I think it's helpful to me to talk to people, talk to patients, talk to providers. So in a second, we will see a graph that I'm going to spend most of the time talking about. There we go. So if we were in a room together, I'd ask you if you'd seen this before. This is not a new slide, but I want to spend some time on it. Notice that there's two parts of this slide. So at the top of the graph, the top graph, you have on the left glucose. And I want to talk about the top first, but I want to point out that this is a timeline. So at the bottom there, it says onset of diabetes. So 0 is when a person actually is diagnosed. And then to the right of that, you can go all the way out 30 years post diagnosis. And then we have 10 to 15 years before the diagnosis. So I want to talk about what's really happening throughout this whole process, the natural history of type 2 diabetes. So on the top graph, we have post-meal glucose is the gold line, and we have fasting glucose is the red line. And notice that starts going a little above normal at the onset of diabetes because that's how we diagnose diabetes these days. Fasting blood sugar of 126 or higher. But notice what's going on about 8 years before the diagnosis of diabetes is that the post-meal glucose is too high, but we don't generally pay a lot of attention to that. So we know that's going on with type 2 diabetes. So let's look at the bottom graph. And we have 4 things that I find very interesting. About 15 years before diagnosis of diabetes, we have insulin resistance in a person with type 2 diabetes. So that's the blue, the neon blue line. And then we have the insulin level is the next brown line there. And notice that it's mimicking the insulin resistance. So we have a lot of extra insulin on board for a while, kind of covering that insulin resistance. Now look at the next line, the green line, the neon green line. It's the incretin effect. So that's the incretin hormones. The one we know most is the GLP-1. It's just continuing from about 15 years pre-diagnosis. It's just going down. There's less and less being produced. And then notice also the beta cells. The beta cells that make the insulin are basically dying off. So those two things are going on, and they're just going down the entire time. They never recover. Notice, so putting this all together, 10 to 15 years before diagnosis of diabetes, there's a lot of things going on in the main resistance, and then the beta cells that are still functioning are just producing tons of insulin to try to cover that. Notice that about between 5 and 10 years before diagnosis, the insulin level can no longer keep up. So the beta cells are dying off, the insulin level starts going down, and notice that at the top graph, what's happening, the post-meal blood sugar is going up because we don't have enough insulin on board. There's not enough incretin hormone to help that. So we've just got a cascade of effects going on. So if you could advance the slide, let me see if I can do it. Well, it's not working for me, but if you would advance the slide, because I have a question or two for us to consider. So thank you. What's going on 10 to 15 years prior to diagnosis? What can we do with the patient? What can we talk to the patient about? So advance the slide again, and we'll go back to the chart. And I'm just going to ask the question, if anybody wants to unmute themselves and say, what would you do if you had a patient that came to see you and you know that they have a history in their family, or for whatever reason you just sense that they're in the prediabetes range? Maybe you've already gotten an A1C. What would you talk to the patient about, or what would your recommendations be?
I would look at the patient's weight. Have they gained weight? What's their physical activity level?
Yeah.
And discuss their nutrition with them. Look at their lipid panel. I think those are all really good indicators that are telling us, as you said, 10 to 15 years in the future, we may be heading towards diabetes.
Right. So thanks, Tracy. That was very helpful. And exactly where I was going. So if you've got a patient in the prediabetes range, or at least the time, whether you have labs or not, you're going to want to talk to them. Now, we probably all know that people with prediabetes or predisposes to diabetes in general are usually overweight, and a lot of times they're inactive. We also know that losing a little bit of weight will help the insulin resistance, and we also know that exercise helps insulin resistance. So if we, at this time in a patient's life, can get them to change their lifestyle to help these things, now's the time to do it. So this is why the National Diabetes Prevention Program is being pushed throughout the United States. I'm helping with one right now. We're trying in West Virginia, trying to get more and more of these in different rural areas so that we have places we can send patients to. So this is the time to do that. Which is another couple of other questions, and we'll also be looking at this chart again. So let's go to the other end now and discuss, what if you have a patient in front of you who's had diabetes for 20 years? And then we're going to talk about that. So we're going to talk about whether weight loss and exercise alone is going to do much, and what would hinder this person from losing weight or exercising. So next slide so we can see the chart again. Looking at 20 years or so after this patient so they've had diabetes for 20 years. Maybe you just inherited the patient. And they're overweight. They're not exercising. And let's just, for the sake of argument, say they're on at least metformin and maybe one other pill, or maybe two other pills. Would this be a time that you would really want to push weight loss and exercise before you did anything else? And I'm assuming that their blood sugars are not well controlled. So if anybody wants to give their opinion, please unmute and shout out the answer.
I see my providers using a dual approach. Often they are adding medication at that point, but they're also sending patients to me, and we do actively, aggressively work at their nutrition and meal planning, and also getting physical activity. I do see some improvements, but again, it depends on the patient. You know, do they have multiple other comorbidities? Do they have barriers to actually being physically active? What are, you know, their other health conditions? So some patients I do see good improvement. Others I do not. Again, it just comes back to what else is going on with that patient.
That's exactly what I was thinking. You sort of have to look at the entire person in the entire situation. If you've got a well-motivated patient who's, their life situation has changed and they're going to be able to do some of these things they couldn't before, then certainly you try that. But yeah, you emphasize diet and exercise along with whatever else you're doing.
Mhm. Yes. Thank you, ladies. I I have a weird connection, so I probably didn't hear everything you said, but I heard most of it probably. And I totally agree. Individualized treatment. I do want to point out some things that I have seen when I've talked to providers. My last job, I called on providers and talked diabetes. I've talked to providers, I've talked to patients, and what I have seen is sometimes if you've got a patient that's had diabetes for a very long time and they're not well controlled, this patient has been, I've seen a lot of patients that have been browbeaten, well, just eat better, just exercise more, and nobody's doing anything with their medication. So I just want to remind people that if a patient's blood sugar is way out of control and you know they need to exercise and diet and they've had diabetes for a long time, remember their beta cells are probably not functioning very well at all. And at in fact, I forgot to say that at diagnosis, I mean, back at ground zero, about half of the beta cells at least are non-functioning. So, and it only gets worse over time. So if the patient is only on some oral meds at this time, and they tell you that they tell you they feel better, maybe they don't know it, but usually if a blood sugar is high, they feel bad. And I've seen patients just give up because, we're preaching to them they need to lose weight and exercise, when I would love to see them put on, just following the guidelines, which I'll show you in a minute, get them on the right medication. Maybe they need a GLP-1 because their incretin hormone is so low. But they're probably going to tell you that they don't feel like exercising, and whether they tell you that or not, they probably don't. And they may be hungry all the time because if they don't have enough insulin on board to get the nourishment into their cells, then their cells could actually be crying out for more food. Everybody that's going to act like that, it's very individual. But just looking at this graph, you can see that naturally the insulin level is going to be low, the incretin hormone is going to be low. We don't know yet how to get beta cells to start producing insulin, the ones that we call having died off. So just keep that in mind. And I agree. I mean, of course, we want people to eat well and to exercise and to have a nice, healthy life. But there's a lot going on with these people. And I think I would just promote getting them on the right drug to feel good and then really get them out there to exercise. And maybe you can have a good conversation. Now, I know that we have Tracy Gillespie on here and she sees patients, and that's great. I have worked at a diabetes center before and it was great, but a lot of patients don't come to those, or they can't get there, or whoever's dialed in may not even have a diabetes center that you can refer to, or the patients won't go. So if you can get them to go, that's number one priority. Send them. And if you don't, then keep in mind these guidelines to follow, and sending them to somebody like Tracy is part of the guidelines. So next slide. Okay, so my main point for today is simply that type 2 progresses over time, and we need to give, as it progresses, our treatment and advice need to progress also. So next slide, please. And as I'm waiting for the next slide to show up, I want to just tell everybody that I'm now working kind of at the community level, and I see that the communities are awesome, and they know a lot of stuff to do for teaching people how to eat or grow their own vegetables, or farmers markets, and helping people there. And they know also how to get people into walking programs or yoga, gentle yoga, or all kinds of different things. I'm seeing that and very encouraged by it. But what I'm trying to figure out now is, how can I let them know if they've got friends or family whose blood sugars are out of control and they've had diabetes a long time, then it's not just diet and exercise. And I want to let them know that they need to get the patient back in to see the providers, or get them to a diabetes educator to find out what's missing. So these are just takeaway messages from the progressive nature of type 2. So remember that at diagnosis, there's a huge loss of beta cells already. The incretin hormones are declining. Replacing those hormones, one, is a viable option, and it goes along with guidelines. And in fact, I've had good results talking to patients. They've been reluctant to go on an injectable because it's not natural. But if you've had that discussion, you can say, well, replacing a hormone may be more natural than actually taking a pill. And so there's a thought there. If you use it, if it helps. Exercise and eating healthy can't replace those. And if it's time to do something with those, then we want them to eat healthy, but maybe that's not the right time for the conversation. Weight loss and exercise helps insulin resistance no matter what time period you're at. I just stuck this in here. Diabetes itself does not cause complications. It's out of control diabetes that causes complications. And I've seen so many patients that just have this attitude of, well, my blood sugar's high, but I've had diabetes a long time and there's nothing I can do about it. If eating well doesn't help the blood sugars, then it's time to adjust the medication. And my last point is, don't withhold medications if the patient is not eating a healthy diet. And I put that in because I have called on a doctor who basically told me that he was not going to do anything for the patient as far as putting them on anything without the patient showing them that they could eat right and exercise right. And I said, have you seen the guidelines about when to do what? And he said no. So before I left, he had a copy. Next slide, please. So what do you do with patients who may have slipped through the cracks? Maybe, you'll see a patient every now and then, you'll go, why didn't you come? Well, why haven't I seen you for a year? Your A1C is really high now. So there's a lot of push out there for population health, and I don't know, maybe you guys are already doing these things, but if you can maybe sit with the ADA guidelines or the ACE guidelines and get your clinical people that are doing population health and do queries in your EMR to, you could do the patients whose A1Cs are greater than 10, but they're not on an injectable, because the guidelines say if they're greater than 10, they need to be on an injectable. Or A1C greater than 9, had diabetes 10 plus years, that are not on an injectable. Or maybe, there's other ways you could do this any way you wanted to. These are just ideas if you're trying to find people that are at most risk for complications, and you might start with the higher end of A1Cs. You could also start the lower end and find patients who are in the pre-diabetes range and then refer them to a national diabetes prevention program. So there's ways to find these patients without waiting for them to come back in. So next slide, please. So this is from the ACE guidelines 2019. I could not find online a 2020 version, but I used to have little pocket guidelines to give out, and I like these guidelines because if you can read it, it says at the bottom left, this is the the recommendation of order of classes of drugs. So if notice at the top, it just says glycemic control algorithm, individualized goals, then it says lifestyle therapy that we've been talking about all along the way. And then you go down to if the entry A1C is less than 7.5, they recommend monotherapy, and first line is metformin. If they can't tolerate metformin, then it would be a GLP-1. If there's some reason T2. So these are in order of recommendation that you would try, and these are the endocrinologists of the world that have put this together. So that's why it's just an easy to read chart. If you've got somebody who comes to see you for the first time and their A1C is greater than 7.5, they recommend dual therapy. They recommend metformin plus, and then that would be plus a GLP-1. And then if they need triple therapy, again, you've got the recommendations there. And they also say that if an A1C is greater than 9 with no symptoms, you could do dual or triple therapy. If they have symptoms like they're thirsty all the time or they're urinating all the time, then they recommend insulin plus or minus other things. So I just point that out to you in case you don't have this. They are online. And if you would just do the next slide, please. And I have a couple of references to show you. So this is where I got the ACE algorithm. I tried to put up the ADA guidelines, but I could not get that to work for some reason. So I just gave you the guide, where you can go to get the 2020 ADA guidelines, and they're both very helpful. I also gave you my phone number. You can text me on that. You can call me, and that's my Marshall email, and it says Slover because if you ever went to Marshall as a student, they leave your email from when you weren't married, so there's nothing I can do about that. So email me, call me, and I hope you could hear most of what I said. I am ready to open it up for questions if I can hear you.
Thank you so much for that, Nell. That was wonderful. And everything, the audio was coming through just fine. So we really appreciate that. We can open it up for questions. Did anyone have any comments, questions about Nell's didactic?
This is Tracy. I'll just say thank you very much, Nell. That was a very good presentation. I love the slides, and I look forward to having them and being able to share those with my providers. I think that's the one thing they struggle with the most is choosing the particular medications. I see a lot of patients in my clinic that are on 4 or 5 injections of insulin a day and only metformin, and our doctors aren't using the GLP-1s. This has been very helpful. Thank you.
So I love GLP-1s because that whole octet that I showed at the beginning, where there's so many defects going on, GLP-1s affect most of those defects. And I've seen patients that you get them on a GLP-1, they lose weight, their hunger level goes down, and the insulin works so much better. So I love GLP-1s, but I'm not a provider, so I can't be prescribing anything. I can just suggest that they ask their doctor about it if they're interested. So.
I have a question about diagnosis. I have a gentleman, and he has very complicated health history. I've been seeing him for only about 18 months. And when he came to me, he told me he had diabetes, and he has never had since I've been seeing him, he's never had an A1C above 6.3. He's not on any medications. He's in his 80s. And so yesterday I saw him, and we were talking about he has really severe peripheral neuropathy. And we were talking a little bit about that. After he left, I went back through his chart. Going back 9 years, I could only find one A1C that was 6.5, and it was 6.5. It was never above that. He's never been on medication. And he's not a heavy fellow. I don't know what his BMI is. He's slim. And so I'm wondering, and he has this peripheral neuropathy. So I'm wondering, does this guy really have diabetes? Is his peripheral neuropathy from perfectly controlled diabetes? Is it idiopathic? So this is kind of a complicated case, but I wonder if you have any thoughts about that, Nell or Nadia.
I could only hear parts of your question, so I'd rather somebody else answer. And if you want to call me sometime just to chat, I'd happy to do that.
I can ask. Yeah.
But if somebody else heard your question, please.
Can they hear me? Yeah.
Go for it.
Can you guys hear me?
Yes.
Okay. Do you know if he's gotten, like, does he have anemia or a history of like blood transfusions with vascular disorder, vascular operations or anything like that?
He has peripheral vascular disease. So he's had not, I don't know if he's had blood transfusions. I could ask him that. I'm going to call him today about some other things.
Mm-hmm.
He doesn't have anemia. He has chronic kidney disease. He has end stage or stage 4 end stage. He's on dialysis. So I don't know if that could be keeping his sugars low.
That's possible. And like whenever he's in the hospital, he doesn't require insulin or anything like that, as far as we know.
That's a good question. I don't think so. He was recently hospitalized. I can look into that.
Okay.
Yeah, I wondered about the dialysis. I didn't know if that could be.
It's possible he just has, just had that one A1C that was 6.5 and he's just maybe pre-diabetic.
Yeah. What would be the significance of anemia or the blood transfusions?
So they can alter the hemoglobin A1C. They can make it look
right.
lower than it actually is.
Right. I knew that. Okay. I'll check on those things. Thanks.
Hey, Dr. Pollywall, I saw that you had a question. Are you able to ask it? I unmuted you. If it's still not working, I can ask for you as well.
Can you hear me now?
Yes, we can. Thank you.
Yeah, I was just, I know, even I would like to use the GLP-1 for my patients specifically. In the last few weeks, one of the GLP-1 has been FDA approved for the primary prophylaxis of coronary artery disease for diabetes patients. So I'm now much more inclined to use GLP-1. The problem is if patient complain of nausea, even with that weekly injection, does somebody has any suggestion to it, like to keep using on the lower dose or switching the GLP-1 to some other GLP-1 and see if that is, that they can tolerate? I mean, I'm really having hard time with this GLP-1 side effect.
Can I answer? Yes. Hi, doctor. So the GLP-1s, whenever we first prescribe them, even like before the patient has even picked it up and we're talking to them about it, we immediately tell them the most common side effect is nausea, but it usually goes away in most people in a few weeks. So actually a lot of the time, if they know to expect that the nausea is coming, they kind of, get accustomed to it and give it time rather than just trying it for 1 week and then, feeling nauseous and stopping it. And then regarding dosing, for example, like Ozempic, you can start at the lower dose and you can prolong the weeks that they're on the low dose. So Ozempic has 3 doses, like 0.25 milligrams weekly, and then 0.5, and then 1. So the recommended start is the 0.25 weekly for 4 weeks. And then if they find that after the 4 weeks they go to the 0.5, I usually tell them, just see if you can tolerate the nausea on the 0.5 for a week or 2, see if it starts to go away. If not, you can go back down to the 0.25 and just extend it for, 2 to 4 more weeks and then try again to go back up.
So 3 to 4 weeks is sufficient for the body to get used to that nausea side effect?
Usually, yes. Usually takes about 4 weeks is what we say, but most people it's honestly resolved within 2 or 3. And then some people, they have had like abdominal problems before, like they have gastroparesis, it's just undiagnosed or they don't realize they have it. And the GLPs, because it slows down the gut and slows down gastric emptying, it can worsen gastroparesis. So if it's someone that has such severe nausea that they're like constantly throwing up, then I would consider like, maybe a gastric emptying study or something to see, do they have gastroparesis after you stop the GLP?
Okay, thank you.
You're welcome.
Are there any other questions or comments?
Someone chatting, or is that just?
Oh yeah, that was that question here. So. All right, well, if there are any further questions for Nell and her didactic or anything regarding today's session, feel free to email me and I'll make sure to have them addressed and sent back to you. I did want to make a quick announcement, and our next session is going to be on March 25th, and Nadia is actually providing our didactic then on hyperparathyroidism and calcemia. So keep an eye out for that. And thank you all. Thank you so much, Nell, for that didactic. We'll be sending out a recap email later this afternoon from this session. So if there are no other further questions, we will see you all next time. Thank you, guys.
Thank you.
Do you guys come